Good day, everyone. I'm Pooja Joshi, your host for today's episode. In this session, we focus on a condition that is common yet often misunderstood: irritable bowel syndrome, or IBS. To help us navigate this important topic, we are joined by Dr. Harshateja, DNB, practicing as a gastroenterologist at Aster Prime Hospital, Hyderabad, a respected expert in functional gastrointestinal disorders. Today, Doctor will walk us through early symptom recognition, simplified diagnostic approaches, and effective evidence-based management strategies for IBS in routine clinical practice. Doctor, thank you for being with us. Let's begin our discussion.
Hello everyone, I'm Dr. Harsha, consultant gastroenterologist, hepatologist, therapeutic endoscopist.
So, doctor, question for you is, what exactly is IBS and how would you describe it in simple terms to a non-specialist?
So IBS means it is known as irritable bowel syndrome. So it's a disease which occurs because of the disturbances between your gut and your brain axis. So simply you can tell the misfiring of gut and brain axis neurons can lead to the symptom presentation of IBS. So along with the gut-brain axis disturbances, you'll have the abnormal flora and increased sensitivity of your bowel. So in layman terms, misfiring of your wirings between your gut and brain leads to irritable bowel syndrome.
In your experience, how does a typical IBS patient present in an OPD?
So to label any patient to coming to my OPD as IBS patient, so generally you need to have three main important clinical features. Among them, the most important thing is abdominal pain. So followed by the stool habits, I can say the change in from hard to loose or loose to hard. So the consistency of the stool is another important thing, and the other is the duration. So majority of the IBS patients in India, in my OPD, they present with pain at the predominant diarrhea type. Means at least they'll have 3 to 4 stools, loose stools per day, pain abdomen, at least 2 to 3 days per week. And the classic symptom which they explain is that the pain is majority of times it get relieved after passing of the stool. So IBS diarrhea predominant are the patients who present to my OPD. So you may ask, what is diarrhea predominant? Generally, IBS has multiple types of subforms. So some may have diarrhea predominant, and the other people may have constipation predominant. So they may have, along with the pain, they may have constipation and a prolonged duration of the symptoms for more than 3 weeks. Or they can be mixed. Some people, they may have for 1 to 2 months, they have diarrhea. Later on, they have a constipation phase. Again, they experience diarrhea phase. And the other is unclassified. So predominantly in my OPD, they present with pain and loose stools. But there are the other subtypes also. So you need to look into that also. So alone loose stools doesn't define IBS. Even constipation with predominant pain, you can label them as IBS.
What are the biggest myths or misconceptions you hear from patients about IBS?
So majority of the IBS people, they are so much anxious and they do window shopping or meet multiple doctors and they do research over Google and all other things. So they have the most common misconception I have seen in my practice is, can the IBS lead to cancer? So that is the most common question the patient asks. Since I am having so many loose stools, can I progress to cancer in a future stage? And majority will ask, will it subside in 1 week or 2 weeks? So the biggest myth is IBS is it's not curable. It can be treated with proper medications and lifestyle changes. So IBS is a chronic and relapsing disease, and it does not cause cancers, and it does not affect other organs too. Whereas contrary to this, IBD can affect multiple organs and it has a predilection to cause cancers. So whereas IBS, it's a benign disease, but it's a chronic relapsing disease and it does not lead to cancer. And majority think the other common myths are it is because of food allergies. So IBS is not because of food allergies. So the lactose intolerance or the other celiac group also is not similar to IBS. So IBS is totally a different entity, and the food intolerance, the lactose intolerance, or the celiac disease is also another entity. So both look similar, but both are different. So the common myths are: can it cause cancer, or is any food allergy, or it is because of any lactose or wheat intolerances. So these are the common myths and misconception I've seen in my patients in my OPD.
What simple screening questions can a consulting physician ask to suspect IBS?
The simple screening questions means the utmost important three things is pain abdomen, consistency and frequency of stools, and final thing is duration of the symptoms. So the pain is the cornerstone for IBS. According to the new Rome 4 criteria, without pain you can't label a patient as IBS. So alone in OPD, so the pain with features suggestive of consistency, change or increased frequency or decreased frequency with a prolonged duration for more than 3 months with no blood and mucus. These simple questions, a consultant physician can diagnose IBS clinically without any further tests.
How do you apply the Rome 4 criteria in day-to-day practice? Can it be simplified for general physicians?
So Rome criteria itself is a simple criteria, so it can be used by even general physicians for the diagnosis of irritable bowel syndrome. So Rome 4 criteria has three components as I discussed previously. So presence of abdominal pain at least 1 day per week, and the pain generally majority of the people they get better with the passage of stool, but for some people the pain may even worsen also. So that is the first important criteria in Rome 4. And after that, that is stool frequency and the consistency. So the change in consistency from one pattern to other, or increase or decrease of the frequency of the stool is another important thing. And the third is the duration of the symptom. So these are the main pillar stones for the IBS diagnosis. So it's a simple criteria. Even the physicians can ask the simple three questions: how many days do you have pain in a week? How many stools do you pass in a week, in a day? And is there any change in the form of the stool recently? And from how many months are you having symptoms? So with these three simple questionnaire, the majority of the physicians they can diagnose in the busy OPD IBS.
Once IBS is diagnosed, what is your first-line approach to management?
So as we discussed previously, IBS has multiple subtypes. So first you need to categorize the patient based on his symptom. Does he group into IBS diarrhea predominant, or constipation predominant, or mixed type, or unclassified? So IBS diarrhea predominant, they'll have greater than 25% of the stools as a loose stools, whereas the constipation has greater than 25% of the stool as a constipated stool, whereas mixed has both greater than 25%, and the unclassified it doesn't fit into any of these three. So IBS treatment along with the part of the doctors, so the patient has to do majority from his personal side also to get better and cured, treated in the IBS. So I would feel the first dietary adjustment will also be the cornerstone for the treatment of IBS. So majority of the IBS people also have bloating along with the pain and change in the frequency of the stool. So try to make a meal so that you have majority of the food doesn't cause much of bloating. So I can simply say you try to categorize the food which has a low FODMAP content. So to simply explain, FODMAP means these are the undigestible products which are present in your vegetables, and with the digestion of it there is so much of gas production, the patient feels bloating. So there are few foods which can have a low FODMAP content so that the bloating and the other symptoms will be less. So try to start low FODMAP diet and low residue diet so that the majority of the symptoms get better with the low FODMAP diet. Few examples of low FODMAP diet are like papaya. You can take oranges, kiwis, raspberries, blueberries, or cabbage, cauliflowers, or any almonds like these dry fruits. So these are the few examples of the low FODMAP diet, and Mediterranean diet is one which has good results in IBS patients for decreasing their symptoms. So first is the dietary changes, and the second one is try to do much of a physical activity, and try to get decent sleep. So along the physical activity and a decent sleep, try to reduce their stress, and they'll be getting better the symptoms over the time when they combine dietary compliance along with the physical exercise, and with the good sleep. I think majority of the people over the time they can get better with these non-pharmacological ways of treating IBS. Along with that, there are few pharmacological treatments. Based on the subtypes, you need to tailor the treatment. So for IBS diarrhea predominant, you can give initially, you can start with loperamide. For constipation predominant, you can start with polyethylene glycol. And the other cornerstone is the patient and physician relation is also utmost important, because it's a chronic disease. Along with the dietary things, non-pharmacological things, and the drugs, the physician-patient relationship, along with the psychological assurance and the counseling, is also cornerstone for disease. Because more than 50% of the IBS people have one or the other psychological component like anxiety, generalized depression. So, if you address that component also, the patient will have a betterment of his symptoms. So, this would be my first line treatment approach for IBS patient.
How important is patient counseling in IBS management? What key messages do you give?
So, as I discussed previously, counseling is utmost important in IBS management, because along with the organic component of the IBS, the psychological component also plays a major role. So, as I discussed previously, more than 50% of the IBS patients have a component of anxiety or depression. So, the physician and patient relationship is important in a counseling. Along with that, so you need to first educate the patient in the counseling. So, what is the disease? What are the complications? What is its progress? As we discussed previously, IBS is a benign disease. It relapses frequently. So, the patient must be assured the disease is benign and the symptoms can be controlled with his diet, lifestyle, and his psychological support. Along with the education, he need to be reassured. With the reassurance, if the patient has a compliance for his treatment, the duration of symptoms gap will be more than the patients who relapse frequently because of non-treatment compliance and not following the non-pharmacological methods. So, along with the counseling, assurance, education, and the drug compliance, there is a severity of the psychological component. You can even give a trial of cognitive behavioral therapy so that the patient gets better both psychologically and even with the IBS symptoms. So, that is the key for IBS management.
What's the role of diet? Do you recommend low FODMAP, fiber modification, or any particular dietary pattern?
Yeah, so there is a significant role of diet in irritable bowel syndrome management. So try to, in a simple words, try to eat easily digestible food in a minimal quantities, so that it is good for your tummy and you have less bloating and less pain. So majority of symptoms get better if you try to take low FODMAP diet. As I told previously, so if the FODMAP is low, the less chance of bloating, and the patient gets better. So try to make a diet plan which includes low FODMAPs. And coming to the fiber, so majority of IBS people they can't digest fiber. So try to give the soluble fiber component like psyllium husk, ispagula husk, so that the soluble fiber gets digested easily, and it will help to form the bulk of the stool. Along with that, the bloating and the pain component also decreases significantly. So, along with the low FODMAP and the addition of soluble fiber, the other things you need to do in the diet is try to avoid caffeine, ultra processed food, alcohol, and smoking, and try to take food which are fermented like curd or yogurt, or you can try with the standard South Indian breakfast like idli, dosa, and you can try with the poha or anything which has low FODMAP and gives you sufficient calories. And try to take partition meals and low volume meals. So I think these modifications in diet can help the IBS patients in the betterment of their symptoms.
What advice do you give to patients for long-term gut health and relapse prevention?
So once an IBS patient, for example, he has a multiple symptoms with the treatment and dietary changes, he has a symptom decrease over the time. So to have the symptom in quiescence, so he need to try to inculcate the dietary habits which he has started into his day-to-day lifestyle. So try to take probiotics in the food like curd, yogurt, and try to take easily digestible food. Try to avoid the ultra processed food, and try to have a sufficient physical exercise and decent sleep. And the other important thing is adherence to the treatment. And if needed, intermittent CBT therapies, counselings, all these things, they help to achieve long-term good gut health and prevent relapses.
What do you wish every consulting physician understood about IBS?
Every consultant physician should understand that IBS is a chronic relapsing disease like multiple autoimmune diseases. So the main thing I feel is that physician and patient relationship is the utmost important. And along with that, alone one doctor like gastroenterologist alone can't treat complete IBS. You need a help of dietitian, psychologist, psychiatrist, so that it's in a multidisciplinary modality of treatment for any patient of IBS. So, and the other thing is that don't do over investigations, because according to Rome 4 criteria, majority of the IBS patients can be diagnosed with the symptomatically clinical features alone. So try to restrict the investigations and label the patient with the Rome 4 criteria, and look for any red flag signs. If there are no red flag signs, try to decrease the investigations, develop physician and patient relationship, and try to focus with a multidisciplinary team approach so that it will be a betterment for the patient.
What's your gut-friendly morning habit?
So, gut friendly morning habit. I would say try to have at least half liter of lukewarm water along with the just a physical activity of at least 45 minutes in a day, so that your day starts good and you feel active over the day. And along with that, try to, as we discussed previously, try to have a minimalistic meal so that it digests easily. So try to add in the morning yogurt or curd along with the easily digestible idli, dosa, poha, anything which is easily digestible, and partition meal along with that lukewarm water with the physical exercise as a mandatory thing. If you inculcate in a long run, it helps in the decreasing your symptoms and have a good life. So thanks, Lupin, for giving me this opportunity on discussing irritable bowel syndrome, and how do you diagnose, how do you manage, and how do we treat, and the role of multidisciplinary team approach, the multiple doctors as a team, along with the patient directed tailored therapy is the way to go for IBS management. Thank you.
Thank you, Doctor, for sharing such valuable insights on IBS. Your clarity and practical guidance will certainly help both physicians and patients approach this condition with more confidence. To our listeners, thank you for joining us. Stay tuned for more expert-led conversations. Until then, take care and prioritize your gut health.